Hello, advanced type 2 Jedis. This lecture is entitled Using Your Powers and Knowledge to Navigate Your Diabetes. Now, you're going to see some Star Wars themes throughout because this lecture is part of a virtual conference that we're putting on called May the 4th be with you. It's on May 4th. And after the virtual conference, you're going to find this lecture in the video vault. You might be watching it later on. And look out for a lecture by Dr. Pettis, good old Jeremy, on the basics. And I'm talking about the advanced. And there is some overlap, but over the next 20 minutes, we're trying to make our lectures shorter, more succinct, more impactful. I'm going to talk about 3 important issues that literally can save your life. And that's a picture of me down below in the first slide. So the first is continuous glucose monitoring. I know most of you have heard this phrase, this device. Some of you are on them, but it is one of the most important advancements for people with diabetes since the discovery of insulin. Now, it's very important to know how they work and who is eligible. So let me cover the eligibility first quickly. If you're on insulin, even 1 shot a day, you can get a CGM and have it covered. Now, this means that you are eligible. Doesn't mean you're not going to have to fight for a little bit. But when you're on insulin, you should be able to get it. And CGM in type 2s is of vital importance. On this slide, you can see that we have the Dexcom G7 on the right, the Abbott Libre 2 and 3 on the left, the Eversense, that's the implantable 6-month CGM, lower left, and the Medtronic Guardian 4 on the right. I'm not going to be getting into the details, but on our website, you can get these details extremely well explained, all the different devices. Okay, now, these CGM systems have a small sensor inserted under the skin, and it measures the glucose every 5 minutes. There's wireless transmission to either a smartphone or a handheld monitor that has these numbers on it, whatever is good for you. You may not be a smartphone person. And they help you store, process, and display the glucose values. And I'm going to show you examples of that, which is extremely important. Now, the Eversense is the implantable sensor, so it takes a different format than the other sensors that put a sensor through the transcutaneous tissue. Well, in the olden days, what did we rely on to control our diabetes? We had the A1C test that we got 3 or 4 months before seeing our doctor, and we got the glucose meter. You had to prick your finger, and we hate pricks at TCOYD, but not everyone has access to a CGM. If you're a type 2, I don't care if you're on oral medications only, or even if you have pre-diabetes, all the way across the spectrum to being a type 2 on a pump or multiple daily injections. These CGM devices can give you so much more information that can support your decision-making for lifestyle modification, whether it's diet, exercise, but also adjusting your insulin. And these CGMs have trend arrows. They tell you what direction your blood sugar is going, either up or down. And they also have alerts and alarms to warn you before you get extremely high and before you get dangerously low. And they put out great reports. The reports are for you, my friend, and your healthcare provider. And it creates a great opportunity to have a discussion with your healthcare professional about what's going on with your diabetes. There's just an example of a typical download from a CGM, and I have one blown up in a second, and we're going to go through it. Now, just to keep you on the cutting edge, both Dexcom and Libre are coming out with CGMs specifically for people with type 2 not on insulin. So you have the Libre, the Abbott Lingo and the Dexcom Stello. So they don't have a lot of alerts and alarms and things that might distract you or give you alarm fatigue. That's a whole nother topic. So keep your eyes open for these. They're not available yet, but they will be soon. Now, if you're on a CGM, we always talk about time and range. And time and range is the percent of time that you're between 70 and 180. And all kinds of mucky mucks got together at a consensus conference and said, this is the range for people with diabetes. And it should be the range that includes sleeping, before meals, after meals, and exercise. And they said, if you can get 70% of the time in this time and range, that is the goal, or higher, obviously. And 70% turns out to be 17.5 hours a day. Now think about it. It gives you several hours to be out of range, hopefully not on the low side, but they know that it's hard to control diabetes and not everyone can be below 180 all the time. But remember, time and range is important. So here's a download. It's really important for you to become educated how to read your own download. So the first thing I look at is the average glucose. The goal is less than 155. This person's 151. And believe it or not, the average glucose correlates really tightly with the A1C. Now here on these downloads, you're going to see a phrase called GMI. And the American Diabetes Association doesn't want to call it like an estimated A1C. They call it, ready for this? You'll never remember it, glucose management indicator. And a good friend of mine, Ian Bloomer, who's an endocrinologist in Toronto, he calls it the sensor-derived A1C. And I love that phrase. And believe it or not, folks, it's more accurate than your A1C from the laboratory. So this person's doing well with their average glucose and their A1C. Now, what about standard deviation? Extremely important. Standard deviation is how much bounce you're getting. Remember, the less bounce, the better. The goal is less than 50. So this person is bouncing around more than we would like. And then we go right over to time and range. We want it above 70. This person's 64, not too bad. And then, of course, very importantly, time below range. We want it not more than 4% of the time below 70. Now, if you can remember this, 1% represents 15 minutes. So 4% represents 1 hour. And this person is below 75% of the time, which is an hour and 15 minutes a day. On average, they're below 70. And 3%, 45 minutes a day, they're below 55. The goal, of course, below 55 is less than 1%. So this person can fool you. They could fool the doctor. A1C is great, 6.9, hallelujah. But this person has some serious issues, I'd say primarily with variability and hypoglycemia. Now, if you look at the 24-hour profile that every CGM download has, you don't have to be a rocket scientist like me. The way you look at these is that all the way on the left, that's midnight, and then 24 hours. Now, this is a lot of data over the length of your download. You could download your information for 2 weeks, for 4 weeks, for 90 days. And whatever it is, this is your average glucose in the solid line. And then the rectangles that are up and down is how much variability. So you can look at this right away and say, gosh, from midnight till when this person wakes up, their average goes up and the variability goes up. And I'm going to guess that this person has a night shift, whether it works in a restaurant, is a policeman, stripper, male or female. But you can tell most people are more stable at night. And this is what you can focus your visit with your caregiver. How can I get my blood sugars better at night? Not only are their averages high, but there's a lot of variability. And it really helps you focus in on the main problem. And the last thing I want to say regarding CGM, people with diabetes and healthcare professionals speak the same language when it comes to CGM. Time in range is the same, time below range, average glucose, estimated A1C. So you don't have to learn a bunch of doctor lingo to have an intelligent conversation with your nurse practitioner, your endocrinologist, your GP. And so what I do is I scribble down some of the things that I want the patient to take with them, and then I give the sheet to them. And so if your doctor prints it up and they scribble all over it and they put notes on it, ask if you could take it with you and take it home, stare at it and learn from it. And that way you're the first one to pick up any abnormalities. Okay. Anybody on insulin or a sulfonylurea like glyburide, glipizide, Amaryl, you need to have an emergency glucagon kit, just like people with type 1, because they're all on insulin. We have the Gvoke HypoPen, which is at the very bottom of the screen. And then there's the Gvoke Kit, where you can actually give yourself units in a syringe. And then there's the nasal glucagon called Baqsimi. Okay. Now, the next topic is going to be talking about your heart and your kidneys. You cannot talk about type 2 diabetes without talking about your heart and kidneys. They're both chronic conditions that when you develop issues, if you develop issues, the problems are asymptomatic and they can grow on you over the years. And just for you people that are not that great at anatomy, the kidneys are on the right and the heart's on the left. Now, we talk about the ABCs of diabetes care. I do have the Star Wars alphabet there for you fans, but we talk about A1C and aspirin, blood pressure and cholesterol, and diabetes medications that will protect the heart and kidneys. And that's what we're going to focus on the rest of my 20-minute presentation. I got 9 minutes left. And of course, we don't have time in this presentation to talk about lifestyle modification, but lots of really good stuff in the video vault. Now, let's talk about SGLT2 inhibitors, Farxiga and Jardiance. How do they work? They help you pee out excess glucose in your blood through the urine. Your kidneys filter it out and they push the sugar into the urine. And your A1C comes down, your blood sugars look better, but these drugs have other benefits. And that's what I want to talk to you today about. So let's go through the benefits. Here we go. They lower A1C, as I spoke about, and they first were approved to improve the A1C in patients with type 2 diabetes. You lose a little bit of weight, nothing like the GLP-1 receptor agonist that we're going to talk about next, improves blood pressure, and that's always a good thing. These drugs do not cause hypoglycemia. That's important to know. If you take it with insulin, of course, you can still get hypo, but they do not cause hypoglycemia in and of themselves. And they protect your heart and very specifically congestive heart failure. I'm going to talk more about that. Now, there are all kinds of heart problems that people with type 2 diabetes get, and there's heart attacks, and then there's congestive heart failure. Heart attacks are going to be for the GLP-1s. But remember, congestive heart failure is the single most common cardiac condition in people with type 2 diabetes. And it can grow on you slowly. You want to pick it up early. And we're going to talk about protecting your kidneys. Extremely important. Two of the most common problems we see in people with type 2 diabetes. So it's not just treating it when you get it, it's preventing it from occurring in the first place. Now, the first thing I want to tell you, and as you can see in green, it's very important. You want to follow these labs over time. Your serum creatinine, your GFR, which is called the glomerular filtration rate, and 3, something that you probably don't know about, is the urine albumin to creatinine ratio, and you get that from the urine test. It's very standard testing. The serum creatinine and the GFR gets done on a regular chemistry panel that you probably get 2-3 times a year. But your doctor has to order a urine albumin to creatinine ratio. Extremely important. So you can see on this slide, this is a picture of a laboratory. You can see the creatinine, you can see the GFR, and way over here, you have the urine albumin to creatinine ratio. Normal is less than 30. This person is doing pretty well. But you have to get it, you have to document it, and then you have to follow it over time, because the earlier you pick up abnormality, the more aggressive you should be with treatment and the higher chance of nipping it in the bud and preventing it from getting to end stage. So we always look at this chart. On the left, we have the GFR, which is important, and the top, the urine albumin to creatinine ratio, normal less than 30. So if you look at the GFR, it goes from stage 1 all the way down to stage 5. 4 and 5 is getting close to dialysis. So you want to put yourself on this category. Then you look over here, you plot your urine albumin to creatinine ratio, and every red dot that you see there means it's getting to a critical level. Now, what I do as an endocrinologist, the minute I see an abnormality, I say, listen, John or Sally, I want you to see a good nephrologist, kidney doctor, that specializes in diabetic kidney disease. And the other issue that SGLT2s treat is congestive heart failure, the single most common problem cardiac problem in people with type 2 diabetes. It means that your heart doesn't pump blood well enough around to the organs of your body, and you get all kinds of symptoms. And like I said, it gets worse over time, and very importantly, you may not see symptoms in the beginning. So you might get shortness of breath and get chest pain with exertion. You get lightheadedness, leg swelling. All of a sudden, your weight may go up and your energy level go way down. Now, these are pretty common symptoms for all of us, but these are symptoms and you got to have them on steroids. So these are just some of them. You can look more up online, but they can give you an early indication that you have the beginnings of congestive heart failure. So I talked about the kidney test. This is what the test that you need to get if you at all are suspicious. Ask your doctor. EKG, a chest x-ray, and they can see an enlarged heart. In fact, there's a picture of normal heart on the left with a chest x-ray. On the right, you can see it's way wider. And you're not a radiologist, and if you were, you'd be driving a Porsche. But you can see the vessels are thicker, and it's an obvious difference. And then they do a cardiac ultrasound, and they measure the ejection fraction. How good does your heart eject blood? The lower, the worse off you are. And they have certain normal ranges, medium ranges, things like that. So that's a very easy test to get. And then also there's a very simple blood test called the BNP. Ready for this? Beta natriuretic peptide. And it's just a simple blood test. So there are a lot of people out there that say we should screen for congestive heart failure by at least getting an EKG, a chest x-ray, and this blood test. Okay, GLP-1 receptor agonists. There are several on the market now, and the way they work is that normally GLP-1 is stimulated to be released from your gut when you ingest food. It leads to increased insulin secretion, suppressing glucagon, which you don't want after eating, slows down gastric emptying, and that delays how fast your blood sugar goes up. And lastly, very importantly, promotes fullness. We call that satiety. And it reduces the appetite. And that's why everyone's trying to get Ozempic and Trulicity and Mounjaro to lose weight. Whoops. Okay. Here are the main ones on the market. Once weekly, Trulicity, Ozempic, Mounjaro. They start off with low doses. They get to higher doses. Dr. Pettis talked about this in this basic lecture. And the older once-a-day Victoza, which still works well, much better to get that versus not getting anything at all. And Novo Nordisk did produce a pill that is a GLP-1 receptor agonist in an oral form. So that's also option for people that just don't want to take injections. Then there's Mounjaro. That is what we call a dual agonist. Too much information now. It's a GLP-1 receptor agonist. There's an exclamation point instead of a 1. And a GIP, glucoregulatory insulinotropic polypeptide. And they're both approved for type 2 diabetes. And then in a higher dose, even though they use different names, approved for obesity. And that's Saxenda, Wegovy, and Zepbound. And you've seen these on the news because there's been a shortage. So the benefits include improved diabetes control. They do not cause hypoglycemia, just like SGLT2 inhibitors. Weight loss, weight loss, weight loss. And very importantly, they protect against heart attacks and strokes. Now think about all the other benefits associated with significant weight loss. Reduce fatty liver, a whole nother issue in type 2 diabetes. They improve heartburn or gastroesophageal reflux disease. They help osteoarthritis. They prevent pre-diabetes from progressing to full-blown diabetes. And they also have been shown to improve kidney function. So remember, these medications can save your life. And I love this little picture of Yoda. And he said, "You saved my life. You're a lightsaber." I thought it was funny. Okay, so here are the take-home points. CGM can help any person with type 2 diabetes, from behavior modification and lifestyle adjustment all the way to medication adjustment and adherence. GLP-1s and SGLT2s are now the first drug of choice if you have heart or kidney disease already. And that's important to know. You don't have to start with metformin and go through the typical, staircase treatment that the ADA puts out there. And this is your life. This is your diabetes. And you could beat the statistics that scare the bejesus out of all of us when we read about what happens to people with diabetes. Type 2 diabetes is a treatable condition. All right. May the 4th be with you.